Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everyone, and welcome to episode 225 of the Better Health Guy blogcast series. Today's guest is Dr. Robin Rose, and the topic of the show is the long COVID puzzle. Dr. Robin Rose, author of the 28-Day Gut Fix, is a double board-certified specialist in gastroenterology and internal medicine, specializing in gut health and long COVID. She is founder and CEO of Terrain Health, where she practices next-generation precision healthcare, integrating systems biology with an innovative approach that requires a deep understanding of each person's biochemical, genetic, and lifestyle factors. Her comprehensive approach prioritizes patient-centered care by creating healthcare interventions that are more precise, personalized, predictive, participatory, and preventative. Her philosophy is deeply rooted in healing her patients from the inside out so that they will age less. Dr. Robin received her bachelor's degree in Behavioral Neuroscience from Lehigh University, graduating with honors. She then went on to obtain her master's degree in Neuropsychology from New York University. Dr. Robin received her medical degree from the New York College of Osteopathic Medicine, graduating with honors, and was inducted into the Psi Sigma Alpha Osteopathic National Honor Society. She did her postgraduate training in internal medicine, followed by a fellowship in Gastroenterology and Hepatology at Beth Israel Medical Center in New York City, and holds board certifications in both disciplines. Dr. Robin practices longevity medicine, teaching women and men how to achieve their best selves by restoring and optimizing gut health, balancing hormones, and proactively managing metabolic, cardiovascular, and brain health. Maximizing these outcomes will pave the way for optimal health span and performance and looking and feeling your best. And now my interview with Dr. Robin Rose. The topic of long COVID is arguably the most important topic to be discussed today. Millions of people are struggling with complex chronic illnesses in ways that we have never before observed. Today, I'm excited to have a personal hero, Dr. Robin Rose, here with us to talk about her deep dive into the long COVID puzzle. Thanks so much for being here, Dr. Rose.
Thank you so much for having me. I'm delighted to be with you.
Let's start a little bit about how you became so passionate and when it entered your reality. Why did you then decide to make it the focus of your days? And I know from some of your prior conversations, many of your nights.
So at the beginning of the pandemic, well, I was following the pandemic like back in early January because my husband at the time had like many business associates and colleagues in China. So we sort of knew what was going on and I knew it was coming, it was just a matter of time. And then the beginning of March, I went on a business trip and I really didn't want to go. Like I was very teetering on whether or not to go. And then on the way, I came back around March 3rd or 5th or something like that. And literally the night before, I was like, I can't believe I'm getting on a plane again to go back to New York. I'm going to get this, And it still wasn't a full reality yet. Like everything was still functioning, but I just knew. And then there was this guy like that was coughing crazy, like 4 aisles in front of me. And I had like my scarf wrapped around my face. Right. But like, I don't know. And then 4 days later, after I got back, I was like scoping in the GI suite doing my colonoscopies. And all of a sudden I just like out of nowhere, I got this really bad upper respiratory infection. I don't usually get sick. And it just like hit me like a Mack truck. And I was super, super sick, nothing lower respiratory, but I was just really sick, like uncharacteristic, like of how I am, if I usually fight things off easily. And my husband was the only other person to get it, and the kids didn't, which was sort of like a pattern of what was happening. The hospital I was working for at the time wouldn't let me go back to work. I was employed by them. And then I just became super duper obsessed with COVID. Like I had to know all the things. I was, watching webinars from all over the world, trying to listen to world renowned virologists speak on the topic, trying to like understand like how we could treat this. And then I remember it took me like a month or so, but I wrote this like primer on the treatment of long COVID and, basically leveraging all different natural compounds that we have. And I was like, no one really. So it's like not like anyone's reading my primer, but it's all the things we wound up using, in hindsight, like everything about quercetin, curcumin, melatonin, omegas, vitamin Z, like all the things, that you could think about, even obscure polyphenolic compounds too. And I just like wanted to be able to treat myself, people I loved, relatives, family, friends. And and at the time when I was doing this, I thought I was going to maybe die of COVID because I just there was just so much unknown and I was so sick. And then I finally got tested like days and like a week or two later. And then my test sat there for 10 days too. So who knows if if the test was even like a false negative, but I wound up coming out negative. But then from then on, it started my journey to opening up Terrain Health, which I now have today. And once I was really fully in practice by the fall of 2020, and I was doing, a lot of advanced biomarkers on patients. I was doing next generation sequencing of the gut microbiome on everybody. I just was seeing changes that started to evolve, like from, the fall of that year into like early 2021 that just didn't seem right. And I was very disturbed by what I was seeing. And then the other thing that I was noticing, especially when the vaccines came out, was that anything that came through on my medical news feed, that even if it was like a world-renowned PhD or scientist from Canada or from wherever, just questioning, something about the mRNA or like observing things that like we have to keep our eye on, like it would just disappear from the news feed like 24 hours later. So like my curiosity was very piqued about that. And I was like, that's super fascinating and interesting. And then while I was seeing the blood work come in on the patients that were getting vaccinated super early, I was noticing a lot of changes like in white blood cell counts, ferritin levels, the sequencing of their gut microbiome. The people were totally losing their bifidobacteria species and the complete phylum of the actinobacteria. So I just was really like, wow. And then I didn't want to get vaccinated, like with every bone in my bone in my body was telling me not to, but because I was working still, I still was faculty at the hospital. I got one shot and I wound up in the ER for 4 hours because I had a major reaction. So that was the only one I ever got. But anyway, the point is that I started to become very involved. I was knee deep now in everything COVID. I was seeing bizarre things in my patients, like reactivation of herpes and Bell's palsy at a rate that I've never seen, and just like other very bizarre presentations of things in people that I wouldn't really see at the rate that I would normally see. And that's how I got involved in this whole thing.
Yeah, I mean, to your point about things disappearing, I doubt we could have even had this podcast discussion 2 or 3 years ago. A lot of things, even in the online communities, were certainly disappearing as well. One of the first things that I'd like to get is your perspective on what long COVID is. So there is the perspective of long COVID being a spike protein toxicity. There are some people that think that SARS-CoV-2 potentially persists in the body. There are many people that talk about COVID as an unmasker, essentially bringing back to the surface things like Epstein-Barr or Bartonella or Mycoplasma or varicella. Certainly people were seeing higher incidence of shingles after COVID, things of that nature. So how do you see it? Is it activation of SARS-CoV-2 that is persistent? Is it a detox spike protein issue? Is it an activation of other latent things in the body, or is it all of those?
So it's all the things you said. It's all the things. And it's very well documented. Like, this is not like we're guessing or hypothesizing. And let me explain to you what's happening. So first of all, the virus is a bacteriophage. So it basically takes up residence in the gut microbiome, in the bacteria in the gut microbiome. Okay. And if you look under electron microscope, you can see those bacteria teeming with hundreds, thousands of virions. Once the virus is inside the bacteria, those bacteria then start to secrete these very toxic compounds called toxin-like peptides. Okay. These toxin-like peptides, the group I work with in Italy, Dr. Simone Cristone, Carlo Brogna, and Carlo is the one that, discovered that this is a bacteriophage. I think he should win a Nobel Prize if you ask me. But meantime, 99% of the medical community doesn't even know this or realize this. So these phages are very, very dangerous. So not only already do we have significant intestinal permeability, dysbiosis, on top of that, now we have the secretion of these animal type peptides, these toxins, right, that are now being secreted by the bacteria in our gut microbiomes. And these toxins can impact any organ system in the body, whether it's the heart, the brain, the lungs, the kidneys, anything. Many of them are neurotoxic as well. That's just another layer to this whole problem. So that's one. So to me, the gut is ground zero. Now, through our research, we've also been able to understand that the bacteria can manufacture spike protein. So we're able to see through mass spectrometry if the spike protein is of what's called bacterial origin versus if it's of human origin, meaning made by our cells or the bacterial cells. Okay. Now, those bacteria cells, it could be that the virus is the virus is inside the bacteria spitting out more protein, or that the mRNA is inside those bacteria and is manufacturing spike protein. Then you have our cells. So those are your prokaryotic cells. Then you have human cells or eukaryotic cells, right? So the spike protein is a magnet for any cell it comes into contact with. That's why it's great, fine, if you see spike protein in some of these studies that say they found actual circulating spike protein, like Brogna and Cristone did find, their paper was published at least 2 or more years ago, that you can see circulating spike protein in blood, and they looked at actually post-vaccinated patients up to a little over 6 months out, and over 50% of patients had circulating spike protein from the vaccine still. So the thing that you have to understand is that spike protein does not live in the blood. It doesn't want to be in the blood. There's over 24 host cell receptors in our body that the spike protein can bind to. So it's not just the ACE2 receptor, it's many, many different receptors. And that's why it's such a beast of a disease. So it can bind to all these different receptors in our body and wants to gain access and be inside, right? Because once it's inside, it's safe. So if it gets inside the cell, right, on its own, just the spike protein itself, once it's inside the cell, it's going to render that cell senescent. So the spike protein is an age accelerant by all definitions, okay? So the spike protein can be by itself in the cell. The spike protein the reason why so it can be inside by itself. If the mRNA or the lipid nanoparticle can actually bind to any host cell, any cell membrane without a receptor and get inside. And then once the mRNA is inside that cell, it becomes a spike-producing factory. And the same thing with the virus. If the virus gets inside the cell, that cell will also become a spike-producing factory. So you'll keep making spike protein. And then again, if the spike protein's inside the cell on its own, it's not going to be a factory, but it's still going to be a senescent driver where it's still producing all of these inflammatory cytokines and all of these inflammatory, and just breeding inflammation throughout the body and sending signals to adjacent cells through SASP, which is our secretory associated senescent phenotype, okay? And SASP can basically then go to adjacent cells, not that it has to have spike protein inside them, but it can turn them into these sort of like senescent-like cells that behave very similarly. So when you're treating the disease, you're not just treating you're trying to save. You can't, once the spike protein's inside the cell, you can't save it. It's done. Like it basically inhibits all forms of it inhibits autophagy. It completely overrides autophagy. So no matter what you do to sort of induce autophagy, it's likely going to fail. But if you use xenomorphics and you can morph those cells, those adjacent cells that don't have the spike protein inside them, you can save those cells. And then once you've saved those cells, you don't, so it's a very complex, complicated process of clearing the spike protein from the body. And it's a very methodical, stepwise fashion because you don't want to kill those xenomorphics, those cells that can be saved by xenomorphics with senolytics, right? And so it's again, it's a very stepwise fashion and very, very complicated and complex. And it's like, wow, like she just told me all this stuff. This is crazy. I'm sorry. So,
it's funny because I had learned a lot of that in listening to a lot of your talks and researching for this episode. But so much of what I learned in just preparing for our conversation was new information. So I think listeners are going to learn a lot as well. I want to touch maybe a little more on that third possibility. So how often do you see that treating long COVID requires you to revisit things like Borrelia, Bartonella, Babesia? You're in Connecticut, as I understand, or maybe
like all the time. Because, okay, so getting back to what's happening. So you have like this massive cellular senescence, especially immune senescence, and you have crazy bad immune dysregulation, right? So of course, with this incredible amount of immune dysregulation now that you're dealing with, right? And the macrophages are like really, really impacted. The Langerhans cells play a role too, which my brilliant colleague, Shantae Sinatra has been teaching me about too. All of this is playing a role in driving the immune dysregulation and why we see the reactivation of these latent viruses, right? Because normally when you have Lyme, when you have Bartonella, Epstein-Barr, right? We've had all these things, right? And most healthy people can like get over them, you treat them, but then they lie dormant. Same with the herpes viruses, right? So all of these things that normally our body says, okay, go over here, shut up and sit down, right? Because we're very immune regulated. We're in homeostasis, right? And so now you have such massive onslaught of dysregulation that all of these viruses and bacterial infections and so on and they all rear their ugly head because there's nothing to control it anymore. It's like everything is just complete chaos and out of control. And until you restore health and balance to the gut microbiome, to the gut immune axis, to the immune system, these things are going to be very, very problematic, right? And so these are the downstream effects of having the spike protein or persistent virus in our body.
Do you see some people that were tolerant of their external environment? They were maybe living in a moderate amount of mold and mycotoxin exposure, and after long COVID, they also need to improve their external environment to improve their internal environment?
Yes, 100%. Yes. I think the way I describe it is, you always talk about the bucket theory, this. I just think people were living, so many people, because listen, we live in a toxic soup, right? Like we just do. And our bodies are so overwhelmed on a daily basis between everything, the blue light, the LED light, the air we're breathing, the toxins, everything, right? We're just so bombarded. And this toxin is the toxins of all toxins, I call it. Like this is like the beast of toxins. And so now we're exposed to this spike protein, which is not from this world. It really isn't. And so many of us were living right here, like right underneath that threshold, and it just like pushed us over, right? And that's why we're seeing, like we already had an epidemic of chronic disease, but it's like now it's so amplified, right? And we're seeing so much disease in so many people and undefined disorders, like undefined neurodegenerative diseases that don't make sense. It's, because of the way the spike protein works in our body and what it does, and undefined autoimmune diseases and like people walking around with elevated ANAs because of the, autoantibodies and molecular mimicry. And it just hits on so many different, pain points, right, in our biology, that it's able to do these very, very bizarre, unique things to us that we really weren't experiencing at this level prior to the pandemic.
I like the bucket analogy, and I'll use the term Jill Carnahan uses a lot, which is really the focus of my everyday is to create more margin in my bucket, right? Just to create a little bit less in the bucket so it's not overflowing and symptoms thus are improving. Talking about symptoms, it seems to me that there's such an overlap between symptoms of long COVID and other chronic conditions like chronic Lyme or mold illness or heavy metal or environmental toxicity. So I'm wondering if there's anything that you see that is unique or more of a hallmark or more common in long COVID. Are there specific phenotypes that you see of patients? And are there any symptoms that are different in children compared to adults, compared to more elderly populations?
No, not necessarily. I think all age groups can present this, with similar symptoms, right? But let me back up, because I don't really think of it as like long COVID or long vax or whatever. I call them post-COVID conditions and post-vaccine conditions, because everyone's condition could be different. Sure, do you have people that have a plethora of these symptoms, like the chronic fatigue, the brain fog, the post-exertion malaise, the chronic headaches, the shortness of breath, the mast cell activation symptoms, the POT symptoms, all the things, the neuropathy, all the things, right, that like completely are on a spectrum for so many patients, right? And you could have patients that have some that are a lot worse, some that are like a little bit, mildly symptomatic. It runs the gamut, right? But also, what is somebody's post-COVID condition? Is it those symptoms? Is it that they have POTS or mast cell activation? Is it that they had multiple clots throughout their body? Is it that they had a stroke? Is it that they had a heart attack? Is it that they presented with a turbo cancer? Is it that they had an autoimmune disease that they would have never that would have not have reared its ugly head, maybe ever, or maybe years down the road? I don't know. But the point is when you see a pattern to the blood work that we check, right? And you have a good understanding both from a clinical perspective and a biochemical perspective, okay, of what this person's dealing with. And then on top of that, you can layer in the research blood work that we do, where we can actually measure the spike protein, and we can actually see the spike protein inside specific cells in your body. So we can look at that person through the lens of systems biology and really understand like where is their weakest link, to really help them sort of get better faster, or at least resolve some of these symptoms so that you can feel better to get better, right? It's different for everybody. So I don't believe that there is like one set like definition, like, oh, long COVID is just this constellation of 200 symptoms. It can be, but it can be also signs and like the presentation or manifestation of certain diseases that you would have otherwise not have seen in like a young, healthy adult, or even an older patient that's never had a health problem in their life. So I believe that it's really these, I call them post-COVID conditions or post-vaccine conditions, and they behave very similarly.
So in your experience, then, are the patients that are most impacted by post-COVID those that had COVID vaccinations? If it is the vaccine, is it more mRNA versus non-mRNA platforms? Are the people that didn't have a vaccine but maybe had the wild type virus potentially seeing equally severe presentations? Or do you see that those people with severe post-COVID that never had a vaccine and only had the wild type virus? Wondering what your thoughts are on, can it be one or the other or both? What are you observing?
All of it. And I see patients that had the wild type virus first, then got vaccinated and got worse, right? I have patients that had the vaccine And after the vaccine, they also got the virus and then got worse. And with each subsequent infection, they relapse, right? And get worse and worse and worse because, again, it's exposure to that spike protein, right? It's exposure to the virus living in your gut, wreaking havoc, causing more issues, causing worsening leaky gut, leaky brain, impacting all your organ systems over and over again, especially your autonomic nervous system. I see patients that never got vaccinated, had the wild type virus, and got horrible, horrible long COVID, right? Everybody's so different. Again, it's so individually based, and it's, obviously this is all precision medicine because it's so personalized, and everybody, depending again, what their epigenetics look like, right? What their genetics look like, what their epigenetics look like, how were they at the time when they were exposed to either the vaccine or virus, right? Biologically. And, did that set them up probably to experience what they've experienced? But I do find that with subsequent exposures to the virus, whether you're a post-vax person or a post-COVID person, that most patients relapse and get worse. I do find that this then becomes a relapsing remitting mitochondrial disorder. And that's why the people that are 100% better, that I get 100% better, 80% better, 90% better, they relapse when there's any sort of insult that pushes them over that edge again, whether the inciting factor is mental, emotional, or physical. And so we have to build immune resilience, metabolic resilience, mitochondrial resilience in all of our patients, like once they get better, to protect them going forward, because it is a chronic disease that these patients will have to live with.
So building on what you were saying, even if someone already had COVID itself, is there still a cumulative effect of ongoing COVID exposures? Meaning, should we still be attempting to avoid repeated COVID exposures to minimize more chronic illness over time? Should we still attempt to avoid shedding from other people? And is it true that our IQ potentially drops with each COVID exposure?
Yes. You should be trying to avoid getting COVID 100%. The virus, while it may not be while it's more insidious versus patients that maybe had issues with the vaccine, which could be more fast and furious, right, in onset of symptoms or signs, the virus is terrible for you. And every time you're exposed to that virus, you're making trillions of spike protein in your body. Okay. And there are a number of studies now that show in an asymptomatic patient or young person, asymptomatic or mild infection after even just one COVID exposure, how they have brain changes in their brain. They have decreased cerebral blood flow to their brain. They have changes in their gray matter, their white matter. We are walking around with low-grade neuroinflammation, many of us. It is no wonder why so many people, even very young people, are like, I can't remember that anymore. I have brain fog. I don't feel like my attention sucks. And then most of my middle-aged women blame it on, their perimenopausal or menopausal, but not to the degree or extent that we're seeing now, and we have the proof. We have brain imaging on all of these people post-infection that didn't even know they had an infection or had mild infection. So can you imagine, that's just from one exposure, what's happening to us with repeated exposures? I have blood tests in front of me on patients that I just screen when they come in. I'm just screening them, right? Their p-tau217s are elevated, and they're not coming to me for a post-COVID condition. Their p-tau217s are elevated. Their A-beta 42/40 ratios are low. Their transforming growth factor beta 1s are in the 20,000, 30,000, or greater than 40,000. They're not complaining to me. What do I do with that patient? Do I let them smolder and then a year from now or 5 years from now, they have Alzheimer's, or they have some sort of dementia or some sort of neurovascular dementia because of what's going on in their body? This is super serious. Nobody's taking it seriously. Nobody's screening for it. Nobody's looking for it.
Let's talk about a couple of terms that we might talk about later, just so people have some understanding of the context of long COVID. So where does the ACE2 receptor fit into the conversation? You've been known to say that ACE2 is a millionth of the issue. So is there an over focus on ACE2? Are there many receptors that play a role? And then what is the furin cleavage site? What role does that play in cutting spike protein into its S1 and S2 subunits? How does that cleavage site impact the virus's ability to more readily impact our human cells? And then expanding on that S1, S2 subunit, what is the receptor binding domain within the S1 subunit of spike? Is that what is binding to receptors in the body? And while maybe it's too early to go into the treatment that we're going to talk about later, what are some of the high-level treatment goals in terms of ACE2, in terms of other receptors, this furin cleavage site, and the receptor binding domain?
Okay. So the gain of function on the virus was at the furin cleavage site. The prior SARS viruses, okay, this S1, S2 and how it cleaves so aggressively and the way it binds is what the gain of function is. Like when you compare it to the other viruses, it's like exponentially higher, okay? And yes, the fact that it does bind to all of these different receptors, like neuropilin-1, DPP4, like I can name I have a good slide that shows all of them. It binds to all of these different receptors all over our body to all these different cells, right? So that's like a huge part of it. The ACE2, yes, of course, it's like a big deal, like in our lungs, in our gut, like in all these different places, like all over our body, right? But it's these other receptors that I show in a lot of my talks, like whether it's in the heart, the brain, that is driving a lot of the gaining of access of the spike protein to a wide variety of all these other cells. So that's first of all. So that's why. So the fact that you have this enhanced ability for it to be cleaved into the S1, because the S1 is the pathogenic piece of this. And so that is what's driving the disease, right? And like in the prior SARS, the function wasn't as enhanced as it is in this virus. Okay. And then the fact that it can bind with such a high affinity to the host cell receptor. Okay. Now, when you're talking about treatment, it's very important in treatment to be doing two things. You want to be inhibiting that cleavage, right? So there's inhibitors, there's furin cleavage inhibitors, and then also you have receptor binding domain blockers as well, right? So you have things that can sort of like neutralize spike protein, that can bind up spike protein, or that can bind to the receptor with higher affinity than the spike protein to knock the spike protein off that receptor. But yeah, you want to have furin cleavage inhibitors, or what's called fusion enzyme inhibitors, that are on board, and receptor binding domain blockers that are on board, in addition to when you are getting rid of the spike protein in the body, because any free spike that doesn't get bound up, and you want to have binders that bind the spike protein, right? So anything that's not getting bound up after you give, let's say, senolytics, right? You have to make sure you're protecting your healthy cells downstream so that the spike protein doesn't then gain access to those healthy cells if you have any binders that don't bind up every single spike protein. It's very complicated.
So what I just heard you say was the idea of using senolytics and supporting autophagy pre-COVID is very different in the world that we're in now, and that there are some potential downsides of senolytics if you're not thinking about what you just talked about and the release of spike that could cause other problems.
That's excellent. Yeah, you're 100% right. So that's the problem. And the problem is that depending on that person's burden of spike protein, and everyone's different, it's very hard at this point to quantify that. If you're giving too many senolytics, you're going to overwhelm the system and really do even more damage, more harm than good to that person down the road. So you have to be super duper careful in how you're treating that patient and how you're getting rid of spike from the body.
So when we think about spike protein, I want to talk a little bit about testing. So it seems that most people are primarily doing spike protein antibodies. My preference is to have more direct testing rather than indirect testing where the immune system may or may not be responding in some people. So is there a way for us to do more direct quantitative spike protein testing? Does that exist today? Talk to us a little bit then about if we can do a quantitative test, do we need to do something to mobilize spike from cells, from tissue into the blood so that we can get a more accurate picture of the spike protein burden? And then what is it that you envision we need in terms of testing in the future to kind of better manage this patient population? Can the tests that we have now differentiate between spike from vaccine versus natural sequence or wild type? What's the state of spike protein testing?
So my research group that I'm part of, we can measure the spike protein directly. It is available as a research-based test, as a wellness test that people can get through our wellness journey.us. So they can get it there, and I'll explain to you what it does. Yeah, so let's go back to antibody testing. The problem with antibody testing is a few things. First of all, if your body is continually manufacturing spike protein, whether it's from the vaccine or the virus, your antibodies are always going to be super high. And so that's why many people, like on the Quest, the cutoff is 2,500. It's always above 2,500 no matter when and how you test them. And for LabCorp, it's over 25,000, although some people are over 25,000, but, many people are like, let's say 10,000, 12,000, 8,000, whatever they're always making. Then you have the nucleocapsid, the N protein, which only turns positive. That antibody is only going to turn positive after exposure to the virus, to the wild type virus. So then you can say, all right, well, this person maybe was more recently infected, and that's why their nucleocapsid is still positive, and that's why their antibodies are still high, right? So it's very hard to differentiate because it could be that if their N protein's positive and their antibodies are super high, then maybe they did have recent infection because your antibodies are going to wane over time, and that nucleocapsid is going to turn negative too, like over time as your antibody response wanes. It's supposed to wane over 6 to 8 months or so, right? Hence why you needed to get vaccines every 6 months, because whatever. So that's first of all. So that's one thing that's a problem. Then you can also argue, well, if the N protein's persistently positive in somebody for like months, if not, for well over a year or more or years, then it could just be that they also have persistent virus, right? But you don't know. So it's like very indirect, and we really don't know what's going on. It just sort of is an indirect way of saying, okay, based, again, pairing it with the clinical picture, pairing it with when they think they definitely last had the virus or they last got vaccinated, you can sort of hypothesize like what's going on, right? But we're able to directly measure the spike protein through mass spectrometry and understanding the sequence, the protein, the sequence of the protein through their amino acid sequence and so on and so forth. And yes, you can differentiate the spike protein from the wild type virus versus the spike protein from the vaccine, because when the manufacturers, took the spike protein, they put a 2-proline, a PP substitution in. So when the mass spec can pick that up and it can see the 2 Ps, when you do ELISA or antibody testing for the spike protein and they're saying that's a spike, that's not an exact test, because again, it's an antibody test. We're able to exactly see that this is the vaccine spike and this is the viral spike, right? And that you actually have spike protein floating in your blood. Now, you asked about provocation. Yes, I just told you that the vaccine sits inside the cells. It's intracellular, right? So if I test most people at baseline, yes, some people I'll still see it in their blood, right? I still might see it in their blood because at any given time, you still on your body on its own could be like spitting spike out. It could be coming across the gut into the blood, from the back. There's so many different things that could be happening. A cell, you could have apoptosis. A cell could be releasing the spike protein, all these different things, right? So you could have at any one given time, right? But if you provoke the patient, and we do provocation diagnostics, where we have them actually take a sample before they've been provoked, and we have them take a sample after they've been provoked. Because it also is actionable data, because we can also see like, wow, how much is dumping out of this person, right? Or how well is their immune system working, right? Because if somebody had like a pretty decent amount of spike protein at time 0 before they provoked, right? And then they had even the same amount, or it went down after they provoked, that means to be, their macrophages are working, they're phagocytosing the spike protein, or they're, getting rid of it, and so on and so, you know what I mean, on their own. Or you could have a person that has this like a low level, and then all of a sudden it jumps like so many logs, right? After you've provoked them. And that's like, wow, they have a high burden of disease and their immune system is not helping them out. Like their macrophages are not very efficacious in doing the job that they need to do. And so that's first of all. And then on top of that, yes, I can see then if you have spike protein from the virus, spike protein from the vaccine, spike protein from bacterial origin. I can see all those things. The other thing we can measure is we can see if you're making those toxin-like peptides, we see them circulating in the blood. So we can see that as well. And each person has their own unique blueprint of these toxin-like peptides. Nobody looks the same. And we have been able to qualify like what these peptides have the potential of doing inside your body, right? That can help us also personalize treatment. The last part of the study, which isn't commercialized yet per se, like these things that I just spoke about, you can get. But the last part is that through the research I'm doing, and we'll probably in the next month or two we'll get there, is we can see what cells that spike protein, whether it's the vaccine spike, the viral spike, or a combination of both, where are they sitting? Are they sitting in your mitochondria? Are they sitting in specific cells in your brain and neurons? Are they sitting in your skin cells, in your cardiac cells, in your kidney cell, like all the things? We can do a complete mapping of your body and see what your unique blueprint looks like. And it's the actual spike protein. It's not antibodies.
Plus, you then know where to target supporting that person in a more individualized way. Before I move on to the next question, just want to touch on the provocation. So is the provocation for the quantitative spike protein test also with senolytics? And is that where these peripheral blood mononuclear cells come in to release more spike into the blood so the test is more accurate?
Yes, so that's correct. So it's with senolytics. It's with a specific dose, like whether you're a kid, you're a child or an adult, like it could just vary a little bit in the dosing. But what we do is we had to do a bunch of iterations of the provocation, because at first we were using some binders and some of those other things I said that were important to protect the patient. But what it was doing, it was like really sort of masking the real results with the mass spec. Like we couldn't really see what was going on. So you really have to only use senolytics to get an accurate picture of what that patient's burden is. Now, it's not a full quantitative, it is a semi-quant, I just want to say, but it still gives a great insight into what is happening in that person's body. Because after you provoke yourself, after those 2 hours, we are worried, obviously, about your other healthier cells. After that part's done, I use our foundational product, which is Medicinals 9, which is those 9 polyphenol compounds, because all of those, they all work synergistically on the hundreds of pathways that are impacted by the spike protein. What's really important is that 8 of those 9 are binders, like weak binders. Four of those act as senolytics. A handful of them also work as senomorphics, okay? And a bunch of them are also receptor binding domain blockers, and they also block the furin cleavage site. So you're getting that in them like at a decent level, or what they can tolerate. We're titrating them up so that after they've been provoked, they can protect themselves, and we have them get like a box of it, or we suggest that so that they're protecting themselves after the fact.
Amazing. Yeah, I love the Medicinals 9 product, and learning more from you and your team on the application of those. And we'll talk about some of the other products that they're coming out with as well. Wondering what other testing, if any, are you finding significantly helpful in the SARS-CoV-2 spike protein conversation? So I know there's T cell testing for SARS-CoV-2, which in some cases could be an indication of more active current immune interaction, but we know also the immune system is impacted by COVID. Are you using the neutrophil lymphocyte ratio, or NLR? Is that helpful? Are you using the Radiance Diagnostics long hauler panel, which might help some people kind of differentiate between long COVID or post-COVID, post-vax, chronic Lyme, and now even mold to some extent? What's rising to the top of your favorite tools beyond what we just talked about with spike protein?
So I use obviously all of the from the commercial laboratories, what you were just saying, the neutrophil, the NLR ratio, and the NLR, but I'm able also through LabCorp to do a cytokine 13 panel. I found that the Radiance diagnostic was just the same over and over again. It wasn't telling me anything very different than what I already sort of knew. And even patients whose long hauler index wasn't positive, they had post-COVID conditions and post-vaccine conditions. And it's not just about the monocytes. While the monocytes are definitely significantly impacted, right? Like I said, the spike protein is sitting in every cell and in every different type of immune cell too. And our research shows through mass spectrometry that the vaccine is sitting in your B cells, your T cells, like your CD4s, your CD8s, your macrophages, your dendritic cells, your monocyte, like all the things. So I really am biased, I guess, a little bit because I'm utilizing that because I'm getting a plethora more information about that patient, not just looking at one, white blood cell lineage, the monocyte, and obviously there's a few different monocytes, classical, non-classical, intermediate, so on and so forth. I'm very familiar with the test, but I don't think that that's the whole picture. And I need to understand the whole picture. I need to look at that person through the lens of systems biology and understand what's happening. Of course, the macrophages and the monocytes and that dysregulation is being driven, by them, but there's all these other cells that are also driving the inflammatory response and like what we're seeing.
Even prior to COVID, one of my great areas of interest in the Lyme and mold community has been hypercoagulation and the accumulation of fibrin. David Berg, Dr. Ann Corson, Ruth Chris have been mentors in that realm, looking at things like prothrombin fragment 1 and 2, thrombin antithrombin complexes, even some of the genetics with the Pi14G deletion. Commonly, we would use lumbrokinase in many people pre-pandemic. Many are still using that. I still take lumbrokinase daily. But with COVID, coagulation and clotting are far more front and center than ever. So I'm wondering, what percentage of your post-COVID patients do you think have clotting issues? How are you testing for those? Is that something that is also commercially available, similar to the spike protein semi-quantitative tests that we talked about? And then what are some of the things that you're bringing out from your toolbox to support those with clotting issues? Are you using triple anticoagulant therapies? Do you have any concerns about the potential use of things like nattokinase, lumbrokinase, or enzymes in the context of the spike protein conversation?
I do not use nattokinase or lumbrokinase, and I'll explain to you why. As far as the clotting, I send all my microclotting testing to Dr. Jordan Vaughn down in Alabama. I I use it as a diagnostic that I can follow patients with, because my whole thing is I want to bring them from the pathological clotting down to like non-pathological levels. So like anything 2.5 over, or like from that scale of 1 to 4, you can have some mild protein misfolding where you get these beta amyloid, sheets that can form in even a normal patient to a certain degree, right? A normal healthy patient. So I want to bring them back down to that like 1 or 2, like below that 2.5 threshold if I can. I would say well over 90% of my patients that I test, that I do the microclot testing have, 3.5, 4 out of 4, right? I do not use triple anticoagulant therapy. I never have. I think it's very dangerous. I think it's fraught with a lot of significant side effects, and people are then limited in what they can do. I think it's a Band-Aid. I think, yes, it does help with getting rid of the clots, but again, you're not getting to the root cause. What is the root cause that's driving the clots? And that's the spike protein and what it's doing to the endothelium and causing this low-grade endotheliitis that then is like starting to activate the multiple clotting cascades, and is also damaging the glycocalyx and the pericytes and all that stuff. And so if we can address that part, right, then you're not going to have ongoing clotting, right? And again, the medicinals 9 that I use alongside other things that I'm obviously flanking that treatment with, those act, a lot of them are weak anticoagulants. And some of the other binders and things that I use, like pentacin, fucoidone, things like that, those are also anticoagulants and help repair the glycocalyx layer and things like that. So I'm able, while I'm worried when I have patients that have significantly elevated D-dimers, and again, I have this other patient not coming to me for long COVID, her D-dimer is elevated. So like 7 to 8 out of 10 of my patients that I'm just screening for have an elevated D-dimer. The mass population is probably walking around at this point with some level of microclotting, and many of them are probably pathologic. So again, it's like smoldering in these people, and we're not screening for it. And again, because what does that mean? I don't know what it means. I don't know what is in store for that person 6 weeks down the road, 6 months, or 6 years down the road. I'm not sure, but I'm damn well sure gonna be proactive about it and treat it, right? So I use the V9 along with the getting to the root cause of ripping the spike protein out of that person, and then optimizing all the other things that have been damaged downstream in that patient. And 2/3 or more of our patients get rid of the microclots. It goes away when you retest them. So you don't need to use all these things. And then going to the last part of your question about why don't I use nattokinase and lumbar kinase? So I'm a big fan of lumbar kinase too. I really like it. I still use it intermittently in some of my patients for, certain things. The reason is because the enzyme neutrophil elastase was studied by Per Hammarström and Sophie Nystrom. They're out of Sweden, and they did a lot of publications earlier on in the pandemic, and they discovered what's called the Hammarström fibers. And we know that the neutrophils are significantly activated, like post-exposure to spike protein or the virus. And neutrophils then, they release this enzyme called neutrophil elastase. When you study neutrophil elastase in vitro, when neutrophil elastase comes into contact with the spike protein, it immediately, and certain epitopes on that spike protein are exposed, it immediately forms these neurotoxic fibrils. And those neurotoxic fibrils can be anything from tau to alpha-synuclein to amyloid beta. The list goes on. And Hammarström and Nystrom, they really beautifully laid this out and showed how all of these neurotoxic fibrils form, right? And so until you show me a study that other enzymes aren't doing the same thing in our body and activating and behaving the same way, I'm not going to give it to those patients, because I don't want to add more fuel to their fire and have them forming more of these neurotoxic fibrils if I don't know for sure that that's not what's happening, given the evidence that we have currently.
It seems to me that post-COVID, post-vax, that these really have a focus on the vascular system, on the endothelium, the lining of our vessels, endotheliitis or endothelial inflammation. So talk to us a little bit, just briefly, about the glycocalyx, how spike protein impacts that glycocalyx, what that might mean for chronic illness, and then what are some of your favorite tools for supporting the optimization of the glycocalyx itself?
So with the evolving variants, the glycocalyx actually, even though they're less pathogenic, meaning you're not asymptomatic, they actually have a much more higher affinity to destroy that glycocalyx. Another reason to avoid the virus. And so with the destruction of the glycocalyx and the enhancement of heparinase, or being released with these newer variants, you're going to have a very, very big problem from a vascular standpoint for many, many people. So if you don't have destruction of the glycocalyx or the endothelium, then you're not going to have disease really. But because it's happening so easily and frequently, that's what's driving like a lot of disease in many people. So you want to make sure that patients have a healthy glycocalyx, that they don't already have like underlying smoldering endotheliitis to begin with and things of that nature. And there's things that can block that. And again, a lot of the polyphenol compounds can help with that. There's tons of studies that show how they can heal and protect the glycocalyx. The glycosaminoglycans like chondroitin, sulfate, and fucoidone and things like that are really helpful in restoring health and balance to the glycocalyx and keeping it nice and healthy. But again, prevention is super important too, because more insult to injury you're just adding as you expose yourself to these newer variants and the evolved variants, because they seem to have higher affinity for many different cells in our body, our cardiomyocytes, our neurons, this part of the endothelium, the vasculature that we're talking about, and so on and so forth.
I have taken fucoidin daily for some time and was very interested to see that it also plays a significant role in this long or post-COVID conversation as well. I want to talk a little bit about the triad of mast cell activation, POTS, and hypermobility or EDS. So it seems to me that SARS-CoV-2 or spike can activate mast cells in some people, very similar to mold, mycotoxins, Bartonella, parasites, EMFs, all of these things that we've known about. So I'm wondering if your patients are benefiting from interventions to stabilize the mast cells. It also seems like we're seeing more POTS dysautonomia than ever. Do you find that that's also being driven by COVID, by spike? Are you treating it specifically while you're also working on the underlying root causes in parallel? And then the third piece of that triad is this hypermobility EDS, which seems to be more and more of an issue in recent years. Some people talk about mediators from mast cells like elastase, which may break down connective tissue. Wondering if you've seen an increase in hypermobility or Ehlers-Danlos syndrome in your patients. So all of that to ask, how does this triad manifest in long COVID patients, and what are you finding is best to support those patients with mast cell POTS and potentially hypermobility or EDS?
So I think the EDS or the hypermobility part comes into play sort of earlier on, meaning those patients I think are more of a setup or more susceptible for this to happen. I think that patients, when you take a history from them that present with post-COVID conditions and the mast cell activation, they had a history for a long time of like easily sort of like, tearing their tendons and having a lot of orthopedic injuries and being very, hypermobile and flexible and things like that. And I think it's on a spectrum. I think it's a spectrum, right? Like I think you have like hypermobile all the way up to like your Ehlers-Danlos patients. Many of them misdiagnosed, right? Again, because it's a spectrum and there's not really a good test for EDS. Like it's really a diagnosis of exclusion. And I think those patients were a setup. And then it sort of was like, pushed under the rug, or like the can was kicked down the road, like for like dealing with it, because it wasn't a big deal. And now, because they had that underlying condition, they were more susceptible to this problem now. That's what I find mostly happening. And then they have this mast cell activation, and your mast cells, the problem with the mast cells is that, yes, they are being released after the platelets are activated, when you have this low-grade endotheliitis and mast cells are activated. And mast cells are released rather, and then histamine, you have the release of massive amounts of histamine release, along with the cytokines and chemokines and all those things that are happening at that, microscopic level of the endothelium. And you also have the release of TGF-beta-1, 40% of TGF-beta-1 is being released from the activated platelets. And the mast cells, then what's happening is they keep coming into this very chaotic environment. It's almost like a learned behavior, right? That the mast cells keep coming in, and it's sort of like you have to break that vicious cycle. And then the mast cells and the dysautonomia and POTS, I feel like they really overlap in a lot of ways, And because the patients with the mast cell activation, you'll see everything from, let's go back, you'll see overlapping symptoms with the POTS, right? Because I believe the mast cells are also aggravating the POTS symptoms as well. I think they go hand in hand in a lot of patients. So the POTS symptoms, everything from blood pressure, everything that you're automatically supposed to do in your body, you're not, right? It's dysautonomia. So your blood pressure is fluctuating, whether it's high or low. Your heart rate's fluctuating, whether it's high or low. Spontaneous tachycardia, the flushing, the rashes, the neuropathy, the dizziness, the lightheadedness, the headache, those two really. The dysautonomia and the POTS too. I don't care if you have a tilt test and you tell me you have POTS. I don't care. I don't care. Again, it's a spectrum. That you have dysautonomia. All these patients at this point have dysautonomia, driven by the spike protein, driven by the activation of these macrophages, by the vagal nerve being impacted, by that gut immune axis being significantly impacted, all the things, right? So I don't need you to have a definition of POTS. I know you have it. I don't need you to have positive histamine or tryptase or whatever else, an allergist or immunologist. I know you have mast cell activation just because of the mere fact of what you're telling me clinically is going on with you. And so you have to be a detective, and you have to be a really good history taker. You have to take a really good history, and you'll know that these patients have it. Over 80 to 90% of these patients have mast cell activation with some form of dysautonomia, and it overlaps. And so that to me is a huge driver of why people feel awful. And so I really live by the mantra of you need to feel better to get better. And of course, I might have to band-aid a little bit up front because I want people to feel a little bit better, to get a little bit better. So using a nicotine patch up front to really control the dysautonomia a little bit, to knock that spike protein off of those acetylcholine receptors, while I'm sort of trying to address the mitochondria, and I use SS31 a lot. Amlexinox, I love. I'll give the Amlexinox. It's a repurposed drug. It's one of the most amazing drugs out there. It's so safe, so easy to use. It's been dosed bazillions of times in Japan since the 80s, especially for children with atopic dermatitis and asthma. It's an incredible mast cell stabilizer. It's super duper great for neuroinflammation, cardiovascular inflammation. It's an insulin sensitizer. It does all these fantastic things. So I get them on the Amlexinox with their H1 and H2 blockers because I don't want to keep them on H1 and H2 blockers long term. And then I use the Amlexinox as a bridge for that. And I also find that low-dose naltrexone works fantastic too for the mast cell activation. So I depending on where they are in the spectrum, what they need, again, everything's so personalized, based on what that person's going through. But I utilize a lot of those tools up front to get the patient to really start to feel a little bit better so that they can then tolerate the treatments that they need.
And for listeners, SS31 and amlexinox are both peptides. You mentioned inflammation. So wondering what the role of inflammation and neuroinflammation are. Are we seeing activation of the microglia where we're shifting more towards that M1 pro-inflammatory morphology rather than the M2 anti-inflammatory morphology? Are you seeing more anxiety and depression in people with neuroinflammation? And then what are some of the tools that you're thinking about in your toolbox for neuroinflammation? Is there a role for melatonin with the NLRP3 pathway? Is there a role for SPMs, maybe plasmalogen precursors? What are some of your favorites for taming the flame?
So the neuroinflammation is a huge part of the problem because the blood-brain barrier is completely destroyed by the spike protein. The spike protein has a huge affinity for the astrocytes, the pericytes, all those things. And then on the other side, it's destroying the lymphatic system, which helps drain the brain of all the toxins. So you have this wide open border or this wide open blood-brain barrier that's letting everything just fly across it, right? And then you have nothing to get rid of the toxins and the garbage, especially at night when you're sleeping, which is when we're really detoxifying and regenerating. And then on top of that, you have all these patients with such significant dysautonomia and, problems with insomnia and autonomic nervous system dysregulation that they can't even sleep to even try to start repairing and regenerating their body. It's like awful. And yes, melatonin is great for what you just mentioned, but it also significantly helps restore health and balance of the lymphatic system and the blood-brain barrier. So I use it to help with all those things. There's been a ton of studies done on melatonin for that in particular. So I love melatonin. I use plasmalogens, Day and Goodenow's product I love it. It's great for restoring, again, that white matter, gray matter that we know is being destroyed in these patients that we talked about earlier. Again, I love the SS31 because a lot of this is driven by mitochondrial dysfunction, and working on the mitochondria to help reverse the neuroinflammation as well. We use a bunch of different nasal sprays too. We have a Medicinals 9 nasal spray that has a lot of the polyphenol compounds, melatonin, things like that in it that can help, and it pushes right across the blood-brain barrier so you can restore, help again with restoring that imbalance that's happening in the brain that's driving a lot of this inflammation. But again, the root cause is getting rid of the spike protein too, so that you don't have this ongoing, recurring neuroinflammatory state that we're seeing, driven by that spike protein, driven by the accumulation of all of these different neurotoxins, the formation of neurotoxic fibrils like alpha-synuclein and p-tau and beta amyloid and all those things. So, and then the activation of the microglia cells from all of this, it's just it's a vicious cycle, like one begets the next.
So we'll talk more a little later if we get time about the nasal spray. I believe that's the Neural Essence, if I remember correctly. I'm assuming also with the Dr. Goodenow product, is it more the prodrome glia that you're finding beneficial? Or are you also using the prodrome neuro?
I start with high doses of glia up front. And then I tried, depending on if they have significant brain fog or if they have elevations in their neuroinflammatory biomarkers, that will determine how much glia I keep them on. And then I bring in the neuro after they've gone through one bottle of high dose glia. I'll bring in a lower dose of the neuro too.
Glia is a personal favorite. So let's talk a little bit more about brain fog, cognitive decline, dementia, Alzheimer's, especially people that have kind of a neuro-COVID. I know our friend, Dr. Suzanne Gazda, has seen a rapid onset of cognitive issues, even in young people since the beginning of the pandemic. There is some conversation around an increase in the formation of beta amyloid. You also talked about things like p-tau and alpha-synuclein. There could be a detrimental impact of spike on our lymphatic drainage or that cleansing system of the brain that you talked about. So I'm wondering if you're seeing an increase in dementia, Alzheimer's, other neurodegenerative conditions like maybe reactivations of MS or increases in Parkinson's or ALS. Do you think that we will see a tsunami of neurodegenerative conditions like we've never seen before?
So I think we already have. I think it's already happening, and I think it will only get worse with repeated exposure. I see it in young people. I see these markers elevated, associated with symptoms or sometimes without symptoms. I've seen a huge uptick in Parkinson's in young people, in this horrible, horrible brain fog, dementia, forgetfulness, cognitive decline in, young patients, middle-aged patients like I've never seen before. And I've seen almost like neurodegenerative diseases that aren't really like qualifiable. I guess it's not, like, if that's a word, like it's not even falling into the regular category. Oh, you are definitely this ALS, or you're definitely a Parkinson's patient. It's almost like a mishmash because you have the formation of all these different neurotoxic fibrils happening at once in the same patient. So it's like this new sort of spectrum of neurodegenerative diseases like we haven't seen before as well. And so it's really hard in the conventional space to treat these patients because they want to give a pill for every ill and they want to have that diagnosis. But you won't necessarily have a diagnosis. You'll have patients presenting with these motor neuron diseases that look like ALS, but they're not progressing like an ALS patient or acting like an ALS patient. So it's really, and same thing with Parkinson's, right? They have a tremor, but it's not fully falling into that Parkinson's sort of like diagnostic criteria that you're usually looking for. And again, it's sort of like, it's a blend of a lot of different neurodegenerative diseases in some people into one.
So when we hear things like atypical MS or atypical Parkinson's, we probably these days should be thinking about post-COVID as a very high on the list thing to be exploring. I want to talk a little more about the mitochondrial impacts of COVID. I'm wondering if spike itself is affecting the mitochondria. Is it more that COVID has triggered a cell danger response, and now we have this extracellular ATP that's a danger signal where the body is really shifting into a more protective hypometabolic state? Wondering what you're using for exploring the potential of mitochondrial dysfunction. Like, do you even need to do a test? Do you have concerns about some of the protocols that are incorporating statins in terms of their potential impact on the mitochondria? And then are you using things like red light or methylene blue? I know SS31 that you mentioned is a very big one in the mitochondrial conversation. Are you able to, or are you testing for things like intracellular NAD? And then another thing that I learned from researching this conversation was one of the tools that you use called 1-MNA, originally from Poland. What role does that play in supporting your long or post-COVID patients with mitochondriopathies, if that's a word?
I think every one of these patients has mitochondrial dysfunction. I think the spike protein directly and indirectly impacts the mitochondria. I think that all these patients have very poor mitochondrial reserve. And I think what's happening is I think the cardiolipin is directly impacted by the spike protein, which is what helps keep and maintain the structure of that inner mitochondrial membrane or matrix. And that's where we form ATP. So what's happening is, like I explained earlier, the spike protein is an age accelerant, right? So at the level of the mitochondria as well. So when we get older, those cristae, which are, you have many, many folds when you look inside, like when you look at a mitochondria, and then that inside squiggly part where you see fold after fold after fold after fold, all those folds are increasing the surface area, right? So that you have more areas of complex 1 through 4, and you're making ATP, right? And so if you're spitting out mitochondria where there's only like a few folds versus like hundreds of folds, and you're spitting out mitochondria like you're an 80-year-old versus a 30 or 40-year-old, then what do you think is going to happen, right? And the issue is you have to also think about how you're supporting the mitochondria, right? Because you don't want to put your foot on the gas pedal, right, without having like an engine that's working, or so, right? So you need to like basically get the infrastructure in place first before you start giving them all those mitochondrial support, all that mitochondrial support. So that's where the SS31 is a synthetic peptide, but it's fantastic. And that's what it does. It works on cardiolipin to restore that inner mitochondrial membrane and that inner mitochondrial matrix, so that now you're spitting out, more younger, more functional, structurally intact, sound mitochondria, right? And so once you get that going, then you can start giving all the things that are going to help with your, with that mitochondrial support, right? So things like L-carnitine and alpha lipoic acid and creatine at like nice high doses, and, certain amino acids. And I love ketones. I use Kinetic Pro. That's by Longevity Launch. I love that because they're more bioidentical ketones. And obviously, they're going to be much more efficiently used in patients like this, so that you're sort of like the glycolysis part is sort of like, skipped over. And I like methylene blue. I use methylene blue, but it probably shouldn't be used up front. Because again, you're doing what I said. You have to, you want to put the cart before the horse, right? So you have to this took a really long time to figure out, like between all of my brilliant colleagues that I work with, like Dr. Betsy Yurth and Cynthia Keller and, Leonard Pastramo at New BioWeight. And we're still figuring out things every day and like how to dose it. And we underdosed it for so long and we weren't dosing it high enough and for long enough. And then bringing in the other things at the right time. And again, everyone's so different and figuring out what works for them or not doesn't work for them and all those things. So let me go to 1-MNA. So one of my best friends and very dear colleagues, Dr. Betsy Yurth, she taught me this. The issue is like everyone's so NAD crazy, and I'll try to do the best of explaining this that I can, but giving too much NAD is really, really bad, because when you give NAD exogenously, those pathways start to overflow and push down pathways that are going to basically throw off these toxic metabolites. Okay. And so what you want to do is get into a situation where you're able to sort of like through a biofeedback loop, like restore your own NAD pools, right? And avoid pushing down these bad pathways. Okay. And what 1-MNA does, it blocks the enzyme 1-MNT, okay, which is going to essentially help in what I'm saying we need to do. And then I pair the 1-MNA with apigenin, which blocks CD38. And so when you do those simultaneously, you get that effect of what I'm explaining needs to happen in your body without overflowing your system with too much NAD. And it's no wonder why probably more than half or 2/3 of patients, when they get the NAD IV, they feel awful and they have negative effects. And I'm not saying never use NAD, but again, if you're going to use the NAD, you want to bring it in at the right time. And you only want to use a little bit at a time, right? To maybe help restore it faster. I'm fine with that. But you need to be careful too. You really need to be careful.
So just at a very high level, I'd love to hear your thoughts on the contribution of iron dysregulation in this post-COVID conversation. Are people more likely to be iron deficient or iron toxic? Are you seeing low or high ferritins? Is that high ferritin then more an indication of inflammation than iron status? Is the iron potentially feeding some of these other infections that have been unmasked? And might some people need to think about iron binders or chelators or even therapeutic phlebotomy to address their iron overload?
So this is what I see. From the beginning of the pandemic, what I noticed early on, and even 2020 and late 2020, early 2021, was actually, and it was astounding to me because as a gastroenterologist, I always looked at iron studies. But what I was finding was the converse. It was like people had really low levels of ferritin, but normal to high levels of iron. So your iron deficiency should drive your low storage of iron, correct? But that's not the case here. It was the opposite, and I still see the opposite. It's very rare that I see very, very high ferritin levels. I don't see that unless they're really acutely infected or something like that. It's really the opposite. And the reason why, and I always give credit to where credit's due, is Bob Miller, who's brilliant. He taught me, he showed me the pathway. I kept asking him, like, where is this coming from? Where is this coming from? I could be explaining it wrong, so you might want to get him on to...
He's been on before, yeah.
All right, but this is what happens. Apparently, the enzyme HMOX is overwhelmed post-COVID in a lot of different ways, okay? And apparently, I could be getting this wrong, like I said, so I apologize. That HMOX, he made, at least this is how he explained it to me, is needed to get iron into its storage form. Okay. So if it's being utilized at such a high rate over here where it's so much more needed, it's being underutilized in that pathway, or there's not enough of it to push iron into its storage form, ferritin, right? So I think we have to look at that iron deficiency ferritin sort of like ratio a little differently, because people freak out that their ferritin's so low. But I'm like, well, why are you freaking out that your ferritin's so low? Your iron is still normal or even high, right? And then I'm going to start giving them iron and make their iron even higher, which is bad, right? That's bad because we don't want iron to start depositing in our soft tissue and our organs and do the other things that you just mentioned earlier, right? So I tend to like treat the root cause again, right, of getting rid of spike protein, like addressing these downstream pathways that have been affected post, COVID or post exposure to the virus and vaccine, to then sort of rebalance that pathway so that HMOX isn't being used in these other biochemical pathways that it's much needed in because of all the dysfunction that's going on. So then once you restore that, then HMOX is freed up so that the ferritin can sort of go back to normal, right? So that's what I see with the ferritin. I don't see a huge amount of iron deficiency. I don't see the iron low. I see it actually normal or high in the setting of low ferritin.
You mentioned turbo cancers earlier. I'm wondering clinically, are you seeing higher incidences of cancer in your patients? And do we think that's being more driven from spike protein or from the immune dysregulation or other factors that are contributing to what some are seeing as a higher rate of cancer today?
We are seeing, it is proof is in the pudding. There is at least an increase of 10%. If you extrapolate data, it's Josh Sterling's group, and they basically are a non-for-profit that they formed to basically work with, it's an insurance collaborative to help work with the insurance companies because they were having such high death rates in young people or the insured population. And now we're seeing an escalation in disability like we've never seen before. If you look at the healthcare stocks, they're down by 50% or more because the healthcare companies are paying out so much money for all these chronic conditions that they never thought they'd have to, especially in the middle-aged and young. And we are seeing more cancers at exponential rates than we've ever seen before prior to the pandemic. You have to extrapolate lung cancer. Lung cancer has been on a decline since 2 decades or 1.5 decades prior to the pandemic. If you take, that's the only thing that skews the data when you talk to these guys. If you take lung cancer out, then you see there's such a huge increase in all the other cancers. And you can also pinpoint the age groups that you're seeing this in as well. And it's driven by the fact, well, first of all, interferon is significantly impacted. P53, the tumor suppressor gene, is significantly impacted by the spike protein. All of these things are happening, way more than what I'm talking about, that's driving cancer, but it is a direct impact of the spike protein and also the ensuing immune dysregulation and immune senescence that we're seeing.
One of the things that Dr. Klinghardt talked about early on was the correlation between the severity or incidence of COVID in areas that had high levels of EMFs, 5G. Wondering if you've seen any correlation between post-COVID and EMF exposure. Do some patients need to reduce their EMF exposure to support their post-COVID recovery?
So no matter what, all the patients that come through our practice, they go through a full environmental sort of like detail with us. And we're addressing the EMFs in all these patients because I think it does play a role.
So I'm wondering if you find that some people can't tolerate the exact supplement or intervention that you think will help them. In those more ultra sensitive patients, do you find value in limbic system retraining, vagal tonification, and attempts to calm the autonomic nervous system and really create a sense of what my mentor, Dr. Neil Nathan, refers to as safer?
Yes, I 100% agree with that. There's some patients that literally, because they have such significant dysautonomia, so much horror, so many issues with cortisol dysregulation that we have to definitely work on the autonomic nervous system and again get them to feel a little bit better so that they can actually get better. So in those patients, I'll use more upfront, like the nicotine patch, things that will maybe help restore health and balance and function to the mitochondria, maybe use the SS31 up front a little bit more, and at the same time do things that are helping tone your vagus nerve and work on that HPA axis dysregulation. Yeah.
You talked earlier about COVID as a bacteriophage, where the virus enters our own microbiome, potentially leading to a spike protein production factory based on the work of Carlo Brogna. You've spoken about tools in other interviews like amoxicillin or Zithromax with Xifaxan for a week to potentially mitigate or address that internal factory. I've heard that there are some things coming that may also mitigate that aspect of long COVID that are in more of the natural realm. So wondering what your thoughts are there. How do we approach that aspect? And building on that, what tools are rising to the top of your toolbox for really restoring the microbiome, bifidobacteria, Akkermansia, and so on that we talked about?
So I have shifted gear. So I just feel like the microbiome is so destroyed, like on every level, like everything from terrible intestinal permeability to such severe dysbiosis. And the problem is now you have these phages, right? And the gut microbiome is already so compromised that then I'm going to throw antibiotics on top of that and make everything worse. So that's never sat well with me, although that was all we sort of had in our toolbox, right? What I've more recently in the last, I guess, 8 months or so, I was at this conference and I learned about ozonated glycerin.
I love that. I just used some this morning.
And it's a glucose peroxide. And why I really like it to treat the gut is because we know the Japanese have been studying it for several years, because as a treatment for diabetes, actually, but it has significant impact on the gut and the gut microbiome. And ozonated glycerin can kill both lipid coated and non-lipid enveloped viruses. Obviously, COVID is a lipid enveloped virus and other RNA viruses and things like that. And the thing with ozonated glycerin, though, is that when you take it orally, it's absorbed in the very first part of your small intestine. So we came up with a concoction with some of my dear colleagues over from the AOT conference this past spring, Jim Bridge in particular, Dr. Jim Bridge. And we basically mix the ozonated glycerin with chia seeds and a liquid, and we make it into a food so that it pushes into down into the large intestine. And what I love, why I use ozonated glycerin is because when the Japanese have done a handful of studies now showing that the OG kills only the bad bacteria, the bad bugs like, fungi, protozoa, viruses, bacteria. It doesn't touch the good bacteria. It actually doesn't touch it. So I've been using a concoction of that with BHT, butylated hydroxytoluene. And people freak out when they look it up on the internet, but there's so many studies of what it can do. And actually the LD50 on it, we're using it like 500 times below the LD50. People are like misinterpreting it from what's written up as a food preservative. So I do a short course of that because the BHT is an excellent way to kill bacteriophages and also lipid enveloped viruses. So I've been doing a combination of that. And we're trying to study it and we're trying to do befores and afters, obviously, of when the patients take it. Then I know Dr. Carlo Brogna, in partnership with Joachim Gerlach, who's my dear friend and partner, they've been working on a supplement too. It's going to be called the Bronya pills, which can hopefully also treat the phages and the gut. So I use this as part of my treatment. And then also I continue it as part of the restoration and restoring health and balance to the gut microbiome. And then I start throwing things in, like I use antibiotic. So we use that because you're showering the microbiome with all those thousands of beautiful metabolites that you don't have. And remember, that's why we take the probiotics for the metabolites. The probiotics themselves aren't doing anything. It's what they're producing, right? To help us with leaky gut, to help us, feed the good bacteria so that they grow and they flourish and all those things. So I use that. I use a certain type of probiotic. I use zinc, C, and D. I use all these different things to help restore the gut microbiome. Yeah.
I love that. And it's interesting to see people coming back to BHT. That was a big trick for viruses in the biohacking arena probably 20 years ago. So interesting to see that coming back around. You talked about the toxin-like peptides, that there's hundreds of these. The average person may be having 12 to 30 of them. You mentioned earlier that there's some new testing coming in this realm to help personalize treatment. How do we remove toxin-like peptides from the body? Can they be bound with binders? Is it minimizing the intestinal hyperpermeability so they don't cross into the bloodstream?
So lorazepam is a peptide that I use right up front in my protocols because I want to seal that leaky gut up, because I don't want things to continue to leak out, especially when I'm treating the gut and those toxin-like peptides are getting right through that significantly compromised intestinal mucosal barrier. So I use lorazepam up front. I just wanted to bring that up too. The other, at high doses, the other thing is, 3 times a day, 500 micrograms. But the other thing is you have to get rid of the phages in order to stop the production of the toxin-like peptide. So I'm going after the gut first and foremost before I move out systemically to treat the rest of the body. So those things that I was explaining to you that I do up front. And then I'm doing a lot to obviously repair that intestinal mucosal barrier, heal the leaky gut so we don't have that perpetual exposure. Now, the other interesting thing is that the EBU, the Stratos system in particular, we studied it. We're published. We have it's been with the publishers for a while, where it was accepted for publication at the Journal of Mass Spectrometry. In that data set, we took 7 EBU filters, 5 of which were provoked, those patients, and the filters were riddled with toxin-like peptides, not just the spike protein. The spike protein gets filtered by that Stratos filter, but also the toxin-like peptide. So it's another way to sort of decrease the burden if you're trying to achieve some good symptomatic response in these patients, like up front as well. So
you talked about focusing first on the gut, but is it reasonable to think about the high-level approach as essentially blocking the receptors, liberating and binding spike, and then removing it from the body, potentially also still having some antiviral support on board if there is some persistent SARS-CoV-2, and then the liberating of the spike and the removal of those senescent cells with senolytics? Is it that the senolytics in some cases are removing that entire senescent cell with its spike payload, or are they always broken up, and that's the reason that we also need to have a focus on making sure we're binding spike when we're using senolytics?
Correct. The latter is true. It's real. And then you're also, that's why you sort of start low and go slow, because before you maybe really go full on into the senolytics, we're using the Vidasol 9 because at like a lower dose, because of the xenomorphic properties that it will manifest, to save those adjacent cells that I said have been impacted by SASP. And that can save those cells. And then you can go on to then destroying the cells that hold spike protein or mRNA or virus that's replicating, so that you can get rid of the senescent cells and the syncytium, the conglomerate of the senescent cells that are forming in people's body as a result of the spike protein.
So when we hear the word binder, I think most people think of charcoal, zeolite, bentonite clay, things of that are staying in the gut, minimizing that enterohepatic recirculation.
I mean a combination of like chelators and binders. things that can bind the spike protein.
We're not talking about things to block the receptor when we say spike protein binders. We literally are talking about things to bind to and facilitate the removal of spike from the body.
That's correct. That's what I mean by that. So, or like chelators, binder. Yes, that's what I mean. It's going to actually bind onto the spike protein and bring it out and not break it up. That's the other thing, because remember, when you're breaking apart the spike protein, you can expose those epitopes. Remember how we talked about the homostrom fibers? You can expose specific, amino acid sequences or those specific epitopes that can then form on contact with that enzyme, those neurotoxic fibrils. So it's very important that you're keeping that spike protein intact and you're not chopping it up. That's why I avoid those other enzymes or, like bromelain, nattokinase, possibly lumbrikinase. Again, these aren't studied, but if theoretically it could be breaking apart those spike protein, and you don't want that. You want to keep it intact and bring it out.
Your favorite spike protein binders?
So it's in those polyphenolic compounds, right? Like EGCG, quercetin. There like eight of those are binders. Fucoidone is an amazing binder to spike protein. Zeolite is a fantastic binder to spike protein. Silica is. There's a bunch of different things that you can use. And the newer formulation of the sequestrol through Medicinals 9 is really combining a bunch of these binders or natural compounds that can bind to spike with high affinity and bring it out of the body.
Let's talk then about the Medicinals 9 that Joachim Urlach created in an attempt to really block 300 different pathways that are used by the virus, used by spike. You talked about that foundational product that has the polyphenols, the binders, the senolytics containing things like quercetin, rutin, EGCG, luteolin, bicolin, curcumin, hesperidin, licorice, and black pepper.
Got it.
Is that a formula that you use for prophylaxis in acute exposure and also in post-COVID? And would there be different?
Everything and different doses for different reasons. So once, so as a prophylactic, I keep my patients on it, like maintenance therapy and prophylactic, like maybe 2 teaspoons a day or 2 teaspoons Monday, Wednesday, Friday. And if they feel like they've been exposed or they start to feel like they're coming down with something, I have them like increase the dose, to daily and double it, right? And then when you're getting treated for the acute infection, you're taking high doses of it. Like some people will take anywhere from half a bottle to 1 full bottle a day. And then when you're being treated for long COVID, most people are working their selves up, I want to say to, I have them on 2 teaspoons in the morning and 3 teaspoons in the afternoon, something like that. Now, a lot of patients, you have to go low, go slow. It has a really, it has very good bioavailability because of how it's created and the formulation and how it's formulated. And so, a lot of American patients are not used to having these polyphenols in their diet, unfortunately. And I think that they can sometimes at first react a little poorly, as they're detoxing. So you could get a lot of patients, I'll be honest, with GI side effects and things like that, or, worsening brain fog and like almost like herxing a little bit. So that's why when I start my patients, I put them actually on a homeopathy remedy. Like I use Pacana or Guna Deep Cleanse because I want to sort of open up their liver, kidney, lymphatic pathways so that they're moving stuff out. Because remember, most people that are set up for long COVID or that have these significant symptoms, they're so congested, they're holding on to things like so tightly as it is because they really don't have good methylation. They don't have their detox pathways don't work well. So I like to give that to them up front and then also get the lorazepam on board and the binders on board so that they're there, right? So that then once I bring the Medicinals 9 in, these are already sort of there doing their thing so that the V9 is not so sort of like, like lighting a fire. It's more like lighting a candle, so that it's like a slower, easier, like ease in for the patient to take.
So you're opening the drains in the bucket by using some of those homeopathics that you talked about. I'm a huge fan. Building on the medicinals 9, there's also the sequestrol, which I understand is more the binder, and the senescence, which is that support for the senescent zombie cells supporting autophagy. You've also talked about omega-3s potentially being binders of spike as well. So it sounds like we generally want to have that binder or sequestrol on board before we start liberating things with senescence, except maybe in the case that you talked about earlier, where you're liberating with the intention of doing the quantitative spike testing, that then you may want to do the testing and then bring the binder in after, right?
Correct. Yes, because having the binder on board with the medicinal 9, which also has like additional binders and it really was basically skewing the data a lot. It was very what's the word? It was clouding everything. So just using the senolytics on their own and then bringing the medicinals 9 in after just that one dose of senolytic seems to be nice, because again, the medicinals 9 still has those xenomorphics, those senolytics in them, the binders in them to a certain degree, and then they also have they're also receptor binding domain blockers, furin cleavage site inhibitors and things like that. So it does a nice job. The reason why when we're fully going on into full treatment, we have the sequestrol and the senescence is because we're flanking that therapy, that we're flanking the medicinals 9 therapy with those products to really give us like a lot of bang for our buck.
So just recently, the medicinals team also has released Neural Essence. Is that used primarily for prevention, for acute issues, also long COVID? And then can you just give us a sense of the lay of the land of other nasal interventions? Should we, in this day and age, be thinking about nasal hygiene as much as we think about dental hygiene?
100,000%. 100,000%. So every day of my life, I do prophylactic nasal sprays. I'll tell you what I do. So there's a medicinals 9 spray, which will also be launched in a few months, right? That I have access to, that I've been using for a few years now. I don't ever not take it. That will be launched in a few months. I love the Neural Essence. So the Neural Essence is similar to the medicinals 9 spray. There's some overlap in the compounds that are in the spray, but what I love about the Neural Essence, it also has melatonin in it. And we talked about all the amazing things that melatonin does, other than just helping you reset your circadian clock or get your circadian rhythm in balance. But it's so helpful in repairing the blood-brain barrier, the lymphatic system, those astrocytes, all those things. So it's really, really, really important. And the aquaporin 4, all those things. So the Neural Essence is a great tool in your toolkit. I would say most patients will want to take it at night, 1 to 2 sprays in each nostril. It's great for treatment as well. As a prophylactic, you do it that way. As a treatment, I was taking that when I had COVID a few years ago, every 2 to 3 hours, because even having the melatonin on board throughout the day was so useful in treating the acute infection as well. And so it's great for prophylactic maintenance therapy. What I do is I'll give you my tricks. We dilute the ozonated glycerin in sterile water, and we make a 10% nasal spray. So I use the nasal spray, and I do 1 spray in each nostril in the morning, followed by the medicinals 9 spray, 1 in each nostril. And then I do the same thing at night, 1 in each nostril, 1 in each nostril. So I piggyback it, and I do really, really well with that. Because remember, it's the nasopharynx, oropharynx pathways is how the virus is gaining access to your body. So if you can have these things on board, right, that are going to inhibit the virus from attaching, right, to the mucosal cells that are lining that area and gaining access to your body, that's your first main line of defense, right? So you want to be doing this. So even like my patients, like before they fly, before they go to a Broadway show or go to a really crowded restaurant, I would like spray the OG or spray the medicinals 9 like in your nose before you get on the plane, before you go to this big event, that's indoors. So I have my patients doing that because, you should be thinking about these things all the time. And it's such a great way to prevent infection. And even other viruses, like the other coronaviruses, your other RNA viruses, influenza, all these different things, it's going to help you with, right?
I'm also hearing about people starting to nebulize 5% OG, which is interesting as well.
We nebulize 5% and 10% OG. So I start them at 5% and then I increase them up to 10%.
I'm interested in your thoughts on two potential interventions that we haven't talked a lot about, and that is ivermectin and augmented NAC. Have you found application for either of those in your protocols?
So I was using ivermectin years ago, like 4 years or so ago when I first started seeing these patients that were early on in the disease, and so on and so forth. I feel that ivermectin definitely has its place because it can knock the spike protein off that receptor binding domain. And we know from studies that it also helps lower the viral load pretty rapidly, in vitro studies. I don't use it anymore. I found that it really didn't make a big difference, especially with these patients like so far out. And so with the newer variants and so on and so forth, it didn't make a difference in treating the long COVID aspect of the disease process. But I use it and I truly believe in it as a prophylactic. So I use it, I give it to my kids, I use it as a prophylactic and as a treatment for acute infection, any viral infection actually. So it's based on the Brazilian study that was done with 88,000 patients. Pierre Corey was a author on the paper. It was back done near probably in 2021 it was published. I can't remember. I've used it for a really long time based on that study at 0.2 mgs per kg twice a week, every other week. So I'll dose my patients and myself Monday, Tuesday, every other week. So 4 pills a month. Now, if the person starts feeling sick for any reason, whether they think it's a cold, upper respiratory infection, because again, ivermectin has really, really great activity against RNA viruses also. So I have patients either double or triple the dose up to 0.4 or 0.6 mg per kg, depending on how sick they are. And I have them take it for the duration of their illness or until they start to feel better. And that usually helps knock down their days of illness pretty significantly if they already had it on board as a prophylactic and they started it right away.
So speaking of prophylaxis, if you're traveling personally or around large groups of people, you talked about ivermectin, you talked about the nasal sprays, the OG, the Medicinals 9. Are there other things? Are we still talking about vitamin D, vitamin C, zinc, all of those things as well?
That's all on board. That's on board on a daily. Zinc, C, D. I love, again, for the gut as a maintenance, like the antibiotic is fantastic. Most people take it for 6 to 9 months. And then after that, you could sort of just have it around. And if you start to not feel good or slip or something, you can, start dabbling in it again. I love, if you don't take the antibiotic, just doing new butyrate. I love KPV, BPC 157, also to support the gut. Lorazepam. I love if you get sick and you just have lorazepam, you should start lorazepam because again, that most infections are gaining access to the rest of your body right through the enteric, through your gut. And what else? Oh, another thing I didn't mention was pentosan polysulfate or pentosan, which is also a fantastic binder to spike. And a lot of compounding pharmacists can make it into a nasal spray as well. Again, I love the nasal sprays because for not only for the protection of that nasopharynx, but also penetrating the blood-brain barrier and, getting spike protein and binding it there too is so important.
So I'm excited to hear that with EBOO, you're seeing that a lot of this is getting filtered out, that EBOO potentially could be helping to remove spike. The other intervention that we hear a lot about these days is TPE or therapeutic plasma exchange. Wondering if you think that's also going to play a role in these people that are dealing with post-COVID related issues.
So we know anecdotally and even studies that have been published that TPE is effective for patients with long COVID. I don't know if they're following and doing befores and afters on, certain biomarkers and blood work. whether it's just symptomatic or clinical, symptomatic relief that they're seeing in these patients. And also, I don't know about recurrence in these patients. The problem I have with TPE is that you're still using albumin or pooled blood products that aren't screened for virus or for spike protein. So theoretically, there you could be putting bad back into the patient and not realizing it. And because of its initial effects on patients and like what it's doing of the actual filtering of the blood and getting all that garbage out, that patient might feel better. But I'm not sure what it's doing long term or down the road. Where, with the EBU, it's more of a contained system. We're not introducing any pooled blood products or anything like that, right? It's just you're filtering the patient's own blood. I mean, it's the same thing with stem cells, right? And stem cell therapy and PRP and all these things that you're giving back that patient's own blood. But yet, if that patient's riddled with spike protein and persistent virus, is that actually going to be good? And we know that the spike protein is living inside like many of the stem cells. We can test for it. It's in the exosomes, it's in the stem cells. So these are all things that have to be studied and looked at and worked out. And I think it's sad that we're not screening for it.
My last question is the same for every guest. And that is, what are some of the key things you're doing on a daily basis in support of your own health?
Okay, well, I'm trying to get a good amount of sleep because sleep is our foundational pillar where we can regenerate, repair, detoxify, right? We talked about detoxification that the brain, especially the lymphatic system. I try to move as much as possible. I'll admit I don't sweat enough. I need to do more sweating. That's a really important emunctory to get rid of toxins and bad stuff, but I should be doing that more. I try to eat, pretty decently. And I try to manage my stress as good as I can. I think I'm doing a better job at this point in my life because I was, dealing with some personal challenges for a while, but that seems to be getting better. I do a lot of support supplementation. I take the Medicinals 9. I do those nasal sprays every day that we spoke about. I take ozonated glycerin every day, like a teaspoon at least as a maintenance. I take like a ton of zinc, vitamin D with K2, vitamin C. I take annatto every day. I take my B complex because I have the MTHFR mutation. So with methylated folate and B12. I take, at nighttime, I take magnesium. I take melatonin every night, even though I have no issues falling asleep or going to sleep, but I'm taking melatonin for the other benefits that we spoke about because it's like, another thing my patient's like, but I sleep fine. I'm like, I'm not giving it to you to sleep. I'm like, I'm giving it to you for other reasons. And I take this, I don't always, because I'm a little, like, I'll be honest, I'm a little bad with the V9 sometimes. Like, so I take this other supplement too, called Sun Balance by US Enzymes because it has luteolin, quercetin, and PEA in it. And I think that that's really important for just all the, effects that we know that spike and, COVID can have on our bodies. And I think to a certain degree, I'm struggling probably with, exposure to the spike protein and the virus myself. I think many of us are. Most people will tell you the gift that they got ever since that they were exposed to the virus or got the vaccine. My gift was that I already had very intermittent episodic migraines and headaches, and I get them very, very frequently for the last several years. So I have to do things that help me mitigate those issues. And then it's so sad. Like, I feel like doctors are the worst patients, right? And I have this beautiful IV infusion center with EBU and all the bells and whistles and the things that I give to my patients, which I don't give to myself enough. But I try to do a major autoheme therapy with hemalumin. I try to do a high dose IVC with other advanced, sort of like nutritional therapeutics when I can, but I don't do it nearly enough. I give myself cerebral lysin sometimes as well, IV for neuroinflammation and stuff like that, but I don't do it enough. But these are the things that I try to, sprinkle in to my life.
So I think, Dr. Rose, I'm going to email your staff and ask them to book you into the IV lounge there because you are such a gift. You are such a treasure. I love this conversation and really your contributions to, I'm actually getting chills as I say this, but your contributions to humanity as we try to navigate this current world and all of the challenges that we have from it are so critical, so important. And I really just want to thank you and honor you for your incredible life-changing work.
Oh, that is just so lovely. Thank you. That really means a lot to me. That's really nice. Thank you so much.
To learn more about today's guest, check out the links in the show notes. Thanks so much for listening to today's episode. If you're enjoying the podcast, please leave a positive rating or review, as doing so will help the show reach a broader audience. To support the show, visit betterhealthguy.com/donate. To get my newsletter, visit betterhealthguy.com/newsletters. To follow me on Facebook, Instagram, X, or TikTok, you can find me there as Better Health Guy. This and other episodes can be found on Apple Podcasts, Spotify, Amazon Music, YouTube, and Odyssey.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.